Well, welcome to Royal Victoria Hospital, to sunny Belfast. I can't guarantee the weather, but certainly we are very excited and honored to be part of AP Valves for 2016. Perhaps I can start by introducing my colleague, Dr. Mark Spence, his colleague mine, Dr. Colum Owens, and we have staff who have been with us for a long time, Jill, Gay, Susie, Jess, and then we have a guest as well to help us load the valve, Ulf.
And Jackie.
And Jackie as well, she's hiding somewhere at the back. Yeah, she's at the back there trying to help with the load valve as well. So we have a good learning curve, learning and teaching type of case today. And perhaps if I can start off by asking Colum to present the case to you all, and then he'll come back to us and we'll tell you where we are so far. And then Mark will take you some nuances about the portico valve that we hope to use today from St. Jude Medical. So maybe I'll kick off to Mark, and then we'll have plenty of time for discussions and questions. The patient is fully awake and fully conscious, so occasionally you might find him moving and asking questions. That's just part of doing live cases and also part of dealing with patients who are fully conscious and fully awake. So Colum, maybe if you can present the case for us, please.
Okay. Greetings from Belfast again. Let me introduce the case which we'll be doing live today. This is an 88-year-old female who was initially referred with echo evidence of severe aortic stenosis, but at time of clinical assessment initially had no symptoms. At that stage, her echo showed a peak gradient of 75 across her aortic valve with a valve area 0.6 centimetres squared, consistent with severe aortic stenosis. At that time, as she was asymptomatic, we medically followed her up. She again represented approximately a year later with progressive breathlessness and angina, and she was listed for further evaluation by way of coronary angiography. As you can see here, the angiogram shows that the right coronary artery had no significant disease, the left main was normal, the left circumflex had no disease, and in this view you can see in the cranial views that the LED had significant disease in the mid-vessel. So in keeping with our local practice, she had a repeat echo which again showed severe aortic stenosis, and her case was discussed at the heart team MDT. The MDT decided that principally to undertake PCI at that stage, as one of her dominant symptoms was angina, and then to reassess her to see if she was still symptomatic from the aortic valve. So accordingly, in December 2015, Ganesh undertook PCI to her LED and implanted a 3026 Resolute onyx stent, as you can see in the mid-LED, with a very nice result, and then reassessed her shortly after this intervention. So she was seen again after her PCI, and again her symptoms were not that strong. She was free of angina, had no significant breathlessness. Then approximately June time of this year, she was reassessed again and was complaining of progressive dyspnea on exercise. This is her most up-to-date echo that you can see. LV function is normal. The aortic valve is clearly calcified and restricted with a peak gradient across it of 70, a mean gradient of 42, and a valve area again of 0.6. You can see in the short axis view this is a very degenerative aortic valve, quite calcified, in keeping with severe aortic stenosis.
Model 5.
Relevant past medical history: she had a pacemaker in 2010 for complete heart block. She has type 2 diabetes and a previous left retinal detachment. And the decision at that stage, as she was symptomatic now from aortic stenosis, we would proceed with transcatheter aortic valve implantation, which is what we're doing today.
Great.
Thank you, Colum.
Yeah.
So you've had a flavor of what this patient is all about. I guess what I'm going to do now is, the objective of this is a live case. So what we've tried to do here is I'm going to continue working on the patient. So far, all I've done is, because the patient already has a permanent pacemaker, we haven't put in a temporary wire. I have a 6-French sheet on my left side and a 9-French sheet on the right side. I'm going to continue working on Eberhard, and then Mark and Colum are going to go through the CT sizing, how we came to sizing. We're going to split the screen so you can see the presentations and my life working at the same time. And then once I cross the valve, we'll come back to me effectively to wrap up where we are. And what we hope to show you is the thought process before the patient even gets on the table, the thought process on how we chose the valve size, and I think you'll see there'll be some interesting discussions there. And we'd like to also demonstrate to you how the portico valve is loaded and what it looks like live. Is that
Good.
okay with you all?
Yeah, that's everything that you do is perfect, Ganesh. We know that. Everything well organized and great. So before we continue, shall we present the panel? Because
I will give you the money I owe you next.
next time. So the panel members here, it's early with you. It's a little bit later here. But of course, SJ, would you like to present the panel members? Because I'm a little bit intimidated with Chinese and Korean names. I probably sound like an idiot when I say that.
All right. Very distinguished panel here. Dr. Hong from Korea, Kao, Dr. Go, Dr. Lim, Lin, Dr. Park Kyung-woo is here, and Dr. Hsien-Li. He's not here now, right? What is Bhindi? Bhindi, right.
So,
All right.
so we are all ready, and we're really happy that by the end, you know, we have some action. It's very nice. Watch out that the patient is not walking away from you. He's moving his legs already.
No, so you know, Elvas, you know, part of live cases is to deal with these kind of minor interruptions, but you know, we have time, we will take our time. Hopefully we'll demonstrate to you A to Z of how we do TAVI here under local sedation with no sedation and fully conscious patients. It's great to see that we have illustrious and experienced panel, so I'm sure there'll be a lot of discussion points for us to tease out. So maybe at this point I'll hand over to Mark, who will take you through the nuances of how we came about picking this patient, doing this valve, and why we came to it. And at the same time, I'll continue working so you can see everything that we do here.
Perfect. Thank you very much, Ganesh.
Good, thanks, Ganesh. Good, so I hope you all can hear me okay.
Yes.
So we, as usual, we performed a cardiac gated CT on our patient, and we used 3Mencio dedicated software to perform analysis of the aortic root and iliofemoral access. I think hopefully you can see the slide there. And
Not yet.
We analyzed the
We see
it should be
Ganesh
just coming
gifted
through now, I
hands.
hope.
Okay, now we can see it. Perfect. Now we got a
You should
split
see
screen.
some slides of the PowerPoint. Good, good. So that's great. So we analyzed by CT. So you can see at the annular level, we had a diameter maxima of 24, minima of 20. There's a little fleck of calcium on the right of the image towards the left coronary side. The perimeter was around 71 millimeters. And at the LVOT level, we had a slightly smaller perimeter. We had copious large sinuses, and the sinotubular junction was nicely wide. So we also analyzed the iliofemoral vessels. There were no particular problems identified there. The minimal lumen was very satisfactory for a transfemoral approach. So the patient already had a pacemaker in, so our intention then was to treat the patient with a TAVI valve. And we've the aid of the sizing chart that gives us some guide provided by St. Jude's. So if you look at the sizing chart, you can see that at a 71 millimeter perimeter, the recommendation or advice is it's at the upper end of the range for a 25. However, whenever we do the calculations in terms of the oversize that this would give us, it would be a 10% oversize at the annular level. And I suppose extrapolating from the core valve data that Jeff Popma has shown, we felt that we would prefer to oversize a little more than 10%. So we actually have elected, and I suppose this is a point we'd be interested in your thoughts on, to go for a 27, which gives us about an 18% oversize. And we would hope this would mitigate or reduce the likelihood of paravalvular leak. So I suppose I should stop talking and maybe open that up just for maybe a little bit of discussion about that sizing choice. We have the aortogram hopefully looping. We can show you that as well. It just gives you another way of looking at the anatomy. And I'll perhaps hand it over to you for your thoughts on that.
I think that's a very interesting point, actually. And even though I follow your arguing and your recommendation, I would like to ask the panel, maybe Paul, can you, because you're a frequent CoValve user, would you agree with the oversizing of 18 to 20 or 15 between 20 and 20% of CoValve or here with Portico?
Well, I think for this particular patient, you don't have to worry about pacemaker, right? Already implanted.
Okay.
The valve itself looks not so heavily calcified to me. I did not pay too much attention on the CT. So I think oversizing in this patient is not, for me, it's not going to be a particular issue. I mean, the standard oversizing or just a little bit oversizing for this patient, I think will both have a good result.
Well, I mean, I agree. Pacemaker is not an issue, but PVL is an issue. And we have from the CoValve IDE in the US, we know that if we don't oversize between 15 and 20, that we might have an increased PVL. So, Dr. Hong, what's your thought about the sizing?
Selection of the size is smaller is better. The reason why, first of all, the severity of calcium is not so severe. Second one is we will think about the age of the patient. Is almost this year, the patient age is 90. If the patient age is maybe the early 70, maybe overdilation is safe. But the patient age is 90, so the population of the aorta should be considered. So in these cases, if we use the CoValve or self-expandable, I prefer the smaller one.
SJ, what do you think?
For, excuse me, for particular these patients, I want to choose the 27 millimeters, just how mentioned about that we have already pacemaker. However, overall, the other data in CoValve still too much overstretching, more than 15%. Actually, it's may related with pacemaker implantation. So we have very small data, but it's clear depth of device and how much oversizing more than 15% as may related with permanent pacemaker implantation. And so, if the patient had a not pacemaker implantation status, I would like to choose 25, just like Dr. Hong. However, in this situation, 27.
Yeah. Any additional comments?
I agree with Paul's opinion about oversizing this case. 88 years old woman and already have a pacemaker is not the issue. But remember with that, we want to push our indication to the intermediate to low risk. Even we have no cardiac block, but long-term left bundle block status will affect for 10 years, affect the patient LV function.
Yeah. Great.
Table down to the leg.
We in Australia, we do use the Portico valve, and I would use the same approach that Mark does. We do oversizing, and I think in this lady with a symmetrical valve, I mean the minimal diameter and maximal diameter is similar. So I don't think you'll have a huge penalty if you're oversized with valvular regurgitation. So I would be very comfortable with this strategy of oversizing at 18 to 20% perimeter.
Yeah. Well, I mean, I've worked with SJ on this, and he has shown his data, and he doesn't like to oversize too much because of the pacemaker, which I totally understand, but here pacemaker is not an issue. The question is, and I don't have much experience with Portico, I can only talk about basic core valve, and if that's the same algorithm, then, we can discuss that. Are there any oversizing? Because what we've seen is that one of the predictors for permanent pacemakers in Portico is post-balloon dilatation, not so much the depth and not so much the oversizing. So if you don't oversize and you have like a 10%, you have a PVL and you need to post-dilate, that might actually be a risk factor for permanent pacemakers. Mark, are you listening or are you hearing us?
Yes, no, thank you. Yeah, thank you very much. That's a helpful discussion. Yes, I mean, I suppose then if we add in the discussion regarding pre-dilation, post-dilation, our hope is, I suppose, just addressing the pacemaker issue. This patient had a pacemaker implanted for intermittent high-grade AV block. in 2005. So at the moment, the patient actually is intrinsically just having backup very infrequently, about 8 to 10% of the time. And if you see her ECG, you'll see it, I'm sure, later on. Very narrow complex, normal PR interval. So in this 88-year-old patient, we will still be seeking to not damage the conduction tissue further. And our hope at the end of the case still is to have the patient most of the time under her own rhythm, because we think that's more effective in terms of exercise tolerance later on. If we give this patient permanent dependency on a pacemaker, she may feel a little more breathless. And we always do strive to keep the patient in normal intrinsic rhythm, even if she has a backup pacemaker. So in terms of the pre-bill and the post-bill, I suppose we'll come to that, but the minute we do tend with the portico valve, I suppose this is then getting into the differences between the different self-expanding technologies. And some of this is a little bit, personal viewpoint, but I suppose the frame of the portico has a little less metal. One of the design features was to have larger cells. So we tend to pre-dilate to ensure that we get nice expansion of the portico at the time of implantation. That's a strategy we would plan to adopt here. But then we'd be fairly relaxed about using post-dilation. That will be totally dependent on the presence or absence of paravalvular leak acutely. But at the moment, we will plan to do pre-dil to hopefully optimize the likelihood of the valve expanding optimally at the time of implantation. And then we'll just make the judgment on post-dil totally on the presence or absence of paravalvular leak.
So,
any comments on that?
Am I understanding this correctly? You're going to pre-dilate?
Yeah, that's our strategy with portico. Yeah. And I know you will have a contrary view for that.
Yeah, I mean, I wouldn't, but that doesn't really matter because you're doing the live case, and are you more? Are you more? I mean, here, guys, the panel. Would you pre-dilate this patient?
Probably not.
So Paul said probably not.
We routinely pre-dilate.
Yeah, you do it routinely, but so there's okay.
For
Dr.
me,
Hahn? No, he's shaking his head.
Direct.
SJ? No.
No.
Yeah. So I think that reflects
So we got a
there is
split panel.
considerable variation. But our plan, we're going. Yeah, that's good.
Are you pre-dilating?
Makes it more interesting. So I think at this stage we're getting on well here.
Yeah.
So we can maybe catch up just with where we are in the case, and then Ganesh is going to just put it in the big sheath here, but we'll come back to that. We would like to show you the portico loading. So I will go over to the table. We'll get the camera onto the valve, let you see the valve, and it should be a quick. It's a fairly quick valve to load, but it might be nice just to show that. So I will move. Is that okay?
I hope you guys can see what I'm doing as well at the same time.
We're watching you.
I like the discussions so far. It's been very, very good. Oh,
Good.
awesome.
So I think you can see, Ganesh, I think you can see the table here, yeah? So we're just going to zoom in. Ulf here is holding the valve. So it's just worth zooming in to show the differences. I think there's a lot more familiarity with the Evolute and core valve frame and valve. So I hope we're getting a nice zoom shot here. Good. So you can see the slight different shape of the frame here, the much larger cells.
Further down.
You can see that it's more parallel in the inflow portion. You can see the curved porcine skirt,
Follow that up.
and then the leaflets themselves are bovine.
Keep going up.
You can see the commissural attachment point here, and then the three attachment release paddles, which are sort of solid, and
AL1.
you can just see 1, 2, 3 there.
Yeah.
We then have got a couple of reference marks. You can see there's a nodal point here. There's like a double nodal point on this 27 valve. The first nodal point, which Ulf is just pointing at, is at 8 millimeters. Then the next nodal point above that is 10. Is that correct, Ulf? So, any comments just on, that's just taking you through the shape of this valve. So very much more parallel These larger cells, the design intent was, of course, to get more tissue-to-tissue interaction and potentially, or the hope was to have perhaps less paravalvular leak.
All the way
And
up
then
to the
these
heart.
largish cells, which you saw, hopefully to retain
Wire up.
relatively easy access to the coronaries. You can see Ulf here is now, this dedicated loading tool, he puts it in, it's this sort of vertical loading system. You can see it pinched here. There's a little spring load in it.
6.
Are you seeing this okay, yeah?
Now, yeah.
So-
We see the delivery catheter.
So Ulf, try not to move too much
Just
so
keep
the
the device
audience
nice
can
and fixed.
see what you're doing.
I think the cameramen we're having a little, you're
Is
There.
this valve is retrievable like the Eberhard R?
Okay, so you can now see this vertical loading. So Ulf is going to now take the device and begin the loading. You can see it's bathed in fluid here. He opens the spring,
Yeah,
and then
one,
the
please.
3 paddles will hook into their little socket spot.
Side flush first of all.
It sort of clicks in like Lego a little bit. So once it gets an orientation here, and now it can be let go, so it's attached on. And now the second loader, or the assistant here, is turning the wheel, and we're just bringing the outflow portion
Give me this
into
room
the catheter.
Inflow.
One of the things that's worth just pointing out, this valve only needs 2 10-second rinses, so
To the heart.
it's a
please.
fairly fast wash relative to some of the other
Before I
devices
do this,
available.
Can I have the pigtail?
Do you have to do
Can
this
somebody check on
with
this
the
one?
ice saline or just room temperature?
So this
temp?
valve is almost loaded at the moment. He's filling up the little, filling up with fluid here, and this tool is just really to make sure there's no air bubbles trapped behind the leaflets. The larger valve has a little blue tool. The smaller valve, I think, is green. Isn't that right?
So Paul was asking,
You can
is
see the
this,
device is color-coded, so the 27 is yellow.
is this room temperature water or is this ice?
All the way down.
This valve can be loaded. This is just cool. It's not ice, no.
Left thigh.
Is he poking on the leaflets?
Yeah.
So he's just trying. This little tool is it's actually something that the
Give me this
surgeons
rumor
use.
wire.
Looks like you
with
have
the,
to.
with the device. It's just to exclude any little air bubbles.
Looks like that you have to be in contact with the leaflets a lot.
Just go off fluoro for a second.
I think. Well, it's just a little. It's just to exclude any air as it's loaded to make sure it doesn't get trapped.
Okay. Pigtail.
So you can see the device has almost come back into the. So it's very close to loaded here.
Once I have
I'm
the
not sure if
pigtail
you're
in
seeing that
position,
through
just
the
check on
fluid
this.
in the funnel.
Let me know when the wire's up.
Like a glass
No,
of
Mark,
martini.
it looks clear.
Good.
All the way up.
So we're almost there.
Oh, you-
And once you've seen this finished, we'll go back to the table where.
That's right.
Wire out. Let's hook up.
So there's a nose cone which
Yeah.
just has to articulate with the catheter. We leave a little tiny gap. We're almost there.
Keep turning. And aspirate
So
still.
this device is being deployed through the dedicated 19 French sheath.
Okay, that's fine.
So there you go. And just making the final check. So it's ready to go. There'll be one final flush through the back port here.
Stand back.
And Mark, that didn't take too much time at all.
Okay, so there's the loading. So fairly quick, all done without any needs to redo. We've no particular fluoro checks or anything to do, which maybe you've got familiar with some of the Evolute. We just can go ahead now with the device. That's it, ready to go. Any comments, folks?
Yeah, it looks like a shot of martini. The only thing that's missing is an olive.
How do you, please? Aryo,
Very
please.
good. So we're back at the table here. Ganesh, you've been working away. Do you want to update us as to where you're at?
Yes, maybe I'm just going to get a pigtail in and then we'll stop for a second.
So Ganesh has just crossed the valve. We just, in fairly standard fashion, we're just using an AL1. We always exchange our amplatzer over a standard exchange wire and introduce a pigtail rather than introducing the.
Stay in Aryo.
We always introduce the heavy support wire through a pigtail.
Mm-hmm.
Okay, Mark, do you want to take this away?
So we'll just get the pigtail in, and then as a natural pause point, we can give you the hemodynamics and perhaps just recap where we are and field any questions that are of interest. I think one of the things in the discussion, I suppose, that maybe we could either just chat now or later, is just the sequencing of PCI and TAVI in patients that have combined coronary disease and severe aortic stenosis. The surgeons, of course, would do the graft and the valve together. This patient, she's 88 years of age, we sequenced it and actually had a little period of surveillance after the PCI when she improved symptomatically. But within 6 months, she developed symptoms again, and we came to TAVI. Some centers would, I suppose, just do the PCI and TAVI in one setting, or some other centers would do the PCI but plan to perform the TAVI at interval without any further surveillance.
Why not?
So perhaps that's something you may wish to discuss.
So what's the wire that the stiff wire that they're using?
Yeah, so Ganesh is going to show you, he loves to shape these wires himself. So he will show you his shaping of this is an Amplat Super Stiff, so
Can I have both pressures up, please?
that's another point that's worth discussing. We've dedicated wires, the Confida wire from Medtronic, we've the Safari wire from Boston. Lundquist is popular, I know, in America. The extra stiff, popular with Edwards users.
Just doing check on the patient.
So this is the Boston Super Stiff wire. Perhaps that would bring some thoughts.
So you've had a good overview of the patient, a good overview of the technology. So far, what I've done, as I've said before, we've got a 6 French on the left and a 9 French initially on the right. Now I had to upsize, I don't know whether you noticed, I had to upsize the 6 French on the left to a 7 French because there was some ooze around the leg, and you know, it's funny, as you agree, and SJ, it's the small things that can cause problems in the future. So if I could easily ignored it, but that would have potentially led to a hematoma forming. So I've upsized to a 7 French now. We can always close the ProGlide after that. You would have seen me putting a ProStar and 10 French ProStar. Different centers do different things. I know some people like using 2 ProGlides, maybe 3. We have always stuck with the and have had, very reassuring outcomes with it. After that, I put a super stiff wire in the descending aorta, always making sure using a pigtail. The other thing we've adopted is to have a flush on the side arm of the sheath. And that flush is always flushed every 5 minutes to allow the sheath to become constantly flushed. And that, I think, stops thrombus forming with it and then us taking it with a balloon. Across the valve using standard methods, using AL1 and a straight through more. And I think you hopefully should be able to see the looped aortogram just done now. Although the calcification did not appear significant on the CT, one of the challenges of CT obviously is the setting you put on it. I think on fluoro, you can see that there is some calcification in the outflow tract. There is definitely calcification in the leaflets. And the valve is horizontal in nature. So going back to the discussion of why we thought about using the larger valve, as you know, whenever you go on a horizontal valve, and as the valve is being released, especially with cell expanding, it tends to favor the non-coronary side, and it tries to reach to the left coronary side. And that distance actually is a lot more than if you're going perpendicular to the valve. So we felt that potentially may be challenges of appropriate versus 2 millimeter more. And the other important thing to remember with St. Jude's valve is that they do have 4 valve sizes for the same valve range. compared to the other valves. So when we go slightly up, we're only really going 2 millimeter up rather than almost 6 millimeter up. So we went to a sizing about 15 to 18%, which we will know whether it's appropriate or not. This is a resheathable technology, as one of your panel members mentioned earlier on, which allows us then to assess and say, okay, if it looks too big or too bunched up, we can always resheath and take it out and put a smaller valve in. It will not be a good day to do that. It'll be an expensive day, but I'm hoping that this will be the right strategy for us.
Ganesh,
so at the moment I've crossed the valve, the pump is connected, we have full contrast load. The angle we're going to use is about LEO10 caudals 5 is what we're going to be using for the aortogram. Although we took the aortogram at LEO10, it seems to be quite nice there. I will stop at that time, maybe at this point, and maybe ask if there are any questions before we go ahead. So next thing I'll do is to put this manually shaped super stiff wire in the LV cavity. The cavity is reasonably small, so we'll be very careful to make sure that we don't allow the wire to go too much forward, because she has quite a lot of hypertrophy as well, so we'll be very careful about that. Being under local anesthesia, she had a little bit of discomfort, but I've given a bit more local, and she seems more comfortable now, which is great. You've seen the hemodynamics and the gradients invasively, and you can see the rhythm as well as sinus with normal PR and normal QRS. So it'd be interesting, I think, to see what happens to this patient's rhythm and ECG when we deploy the slightly oversized valve.
Ganesh, is there,
Eberhard, NSJ.
yeah, is there a reason that you're using a graded pigtail? Is this just tradition, or is there a specific reason? It's habit, Eberhard, it's just habit. It's no reason at all. We could easily put a normal 6 French and save a few thousand pounds in 1 year, but Great.
just bad habit, Eberhard. Or good habit, I don't know. I think there are some benefits. It allows you to, physically adjust to know where you are in graded field. But apart from that, honestly,
for some measurements, we can use it for measurements post hoc for studies and so on. But if we want to calibrate,
and I guess it comes from, we were fortunate to be very interested on the depth of implantation on angiographically. And having graduate pigtail makes that life a lot easier, so it's easier to follow a same system. And I think that goes back to having a rehearsed similar method for every patient, whether it's live or not live, and so that all the staff around you are fully aware of what you want next and what to give you next, and that makes things a little bit smoother.
Yep.
So I think one of the observations I think a lot of us will observe in our patients who are awake and under local anesthesia is the relative hypertension we face as opposed to the hypotension that is often seen under general anesthesia. So we've given, we actually tend to have to give drugs to lower blood pressure rather than raise blood pressure in the awake patient, because they often have, systolic hypertension and relatively stiff aortas. So we've got aortic pressure of about 180 here. I just think it's an interesting observation relative to the general anesthetic patient.
So what I'm going to do now is I'm advancing the pre-shaped super stiff wire on the REO view. Trying to be careful that we don't pull this wire out. She is quite hypertrophic, so if I don't like the way it looks, then I might redo that.
So,
you can see that
Ganesh,
as well in the apex, so I'm going to leave it there.
Ganesh, there's no temporary pacemaker in this patient,
Yes.
right? So you are going to do a pre-dilatation. Tell us your trick. How do you
No, what
do
we're
it?
going to do is use the patient's own pacing.
Oh, okay.
So there's two ways of doing it. We are fortunate this lady already has a pacemaker, so we'll use a patient's own pacemaker rapid pace. There are times, for example, if I'm doing a BAV and it's an emergency and I don't have the time to poke about trying to get a temporary wire, and you can actually use the Boston wire. And
use the wire
the
to
EP
pace.
guys are very good at this trick. You put a needle under the skin anywhere in the patient, and you put the other clip on the end of the wire, and that forms a circuit for rapid pacing. So you can even do that if you want for rapid pacing.
So I thought you are going to show us this trick.
So we're going to go ahead and do a BAV now.
Yeah, no, we're going to use the permanent system here. Obviously we know the device, we've pre-tested it, so we just attach the header, and we're just patient with our physiologists. They'll pop in and we'll be able to, we know this device is capable of pacing up to a couple of hundred beats per minute, so that should be enough.
So what's your balloon
It's
size?
relatively easy on-off on the screen. These days the screens allow that function.
What's your balloon size?
Yes, this is a 22.
And we're using a pneumonucleus balloon. 22 pneumonucleus.
So the maximum minima was 20 by 24 on the CT.
So I am very conscious that this patient's LV cavity is hypertrophied, so I'm trying to go very slowly not to push the wire too far forward. The only area of this procedure that we still have very little potential control is the risk of perforation of the LV cavity. I know there are a lot of the pre-shaped wires, but the data for them are still, I don't pull anymore, I go a little bit. Can we go to the LEO view? You can see the balloon is taking a awkward angulation, so I think we might have some challenges during the deployment. I think the valve is more angulated than it appears.
Well, it looks a little bit like horizontal, no? It's not.
Okay,
it's not straight up.
Isn't it? It is. Yeah. It's not. No. So this will be a challenge, I think, going forward.
No challenge
so we'll
for you.
I think one of the advantages of the resheathable technology is that we can resheath these technologies very safely. Okay, we're ready for pacing, guys?
You want some more?
180 sounds good. I'm just going to come back the balloon a little bit.
Should we get restless?
Okay, maybe if you can let the patient know we're going to be doing the valve in a second. So
just let her know.
So the hemodynamics are very good, rhythm is still good. So sometimes you see rhythm changes just by advancing the wire into position. Okay, pacing on, please. Yeah, go for it, pacing on. It's okay now.
Okay.
It's a good drop pressure, Mark's can take it up. And pacing off. Store that. So you see that even a 22 balloon does move quite a bit. So I think this 27 valve is probably the right thing to do. Okay, Mark's now, pressure is recovered very nicely and the rhythm is still undisturbed, which is again reassuring. So
just go RAO, please.
I'm just going to take the balloon out and then we can review the BAV again. See if I can push the wire a bit. A bit stiff, isn't it?
That's better.
Yeah.
It's a weak angle in the wire this, yeah.
No, I think it's just the anatomy is done that. So one of the challenges of elderly patients obviously is the degree of calcification in the aorta. And I think some of the stiffness we're feeling when you're positioning the wire in the pigtail has to do with the lack of flexibility of the iliac aorta and arch, which is easy to feel. So let's take the valve, please.
Can we review the balloon fluoro?
Let's do that. Let's do that.
There's a side line if you want.
So the rapid pacing was good. There was good control on it. And as the balloon went up, this is pneumonucleus. So normally these are quite stable balloons, but even at 22, it just floats out quite comfortably. On the CT, I'm not sure whether you appreciate it, there was not much outflow change in size.
The alveoli was slightly smaller. But
so you don't normally see we didn't really see on the echo, it looked a little bit more striking, the septal hypertrophy, but certainly on the CT, it really didn't change very much. I think the perimeter and at 4 millimeter subannular was about 70.1, and then the annulus was 71.4. So So we have the valve now. I hope you can see that. As I think you get a very good detailed analysis of what the valve is all about. So I'm just going to go ahead and deploy the valve, and then maybe then stop to discuss after that. Is that all right?
Yeah, of course.
Well, Ganesh, let me ask you maybe a difficult question. We can see that the balloon is actually pushed out while it's inflated, maybe because of a loss of capture, because the LV actually contract at that moment. So let's say this is a self-expanding device. Let's say if you are doing a balloon expandable on this case, would you rely on the pacemaker, the patient's own device, or still you need another pacing catheter?
That's a very good question.
Because I think the capturing is probably not as stable.
And you brought up a very important point. I guess if this was a balloon expandable case, it would have been too late by now.
Yeah, exactly.
And the other important aspect, I guess I'm just being a bit facetious, but you know, in the balloon expandable valve, the valve size and balloon size would be matched to the patient's anatomy. So the exerted on the anatomy would be a lot more than, maybe we undersize the balloon here, obviously. So going very easily, I'm going to go to LAO now, so we can see it going across the arch. For me, I think the most important thing is not whether it crosses the arch. Just stay on the LV cavity, please. Stay on the LV. A bit more on the LV. Can we go off mag one? Is to watch the wire in the LV cavity, because you know, if the valve doesn't cross the arch in the first time, that's fine. But if the wire moves too much forward, that's not fine. One more mag down.
Mag off.
That's it. Okay, so we can see everything now.
Move your way, Jill.
So we are in our hybrid room.
Jill.
Just pull the wire a bit. You can see the amount of calcification in the arch. Just keep pulling. Yeah, just gently pull. Keep pulling. Keep pulling.
So you can see the slight kink that develops in the back of the device, which helps to get around the arch.
Keep pulling the wire. Okay, and stop that. So let's go back to the implant view and come back to the heart. So would somebody let the patient know that we are just going to deploy the valve now, and we'll come back and talk to him in a minute.
So if you just look at the handle here, you can see it's a dedicated handle. There is a stop point at about 80%, but that's really just at 60% rather, which is just a reference point. We've got a wheel which we turn, which draws back the catheter. This wheel can be turned in the opposite direction to recapture the device. So we can deploy the device to about 90% or so, and then check and resheath if need be, and reposition.
Okay, go ahead. Patient right? From me. So I'm just going to cross the valve now. Mark's going to gently pull, knowing that we had some difficulty getting the balloon across. It's important not to force things too much. You'll allow the heartbeat to take its own time as well. There we are. That's good. Store that for me.
Just check wire REO.
Go to REO for a second. We'll just check the wire to make sure it's okay. The wire looks fine. We can pull it back a little bit actually if you need to. We don't really need the wire to. Perfect. Okay. So let's go back to the implant view now. So you can see that the nose cone is easy to identify. You have a little darker shadow just where the sleeve begins. And then there is a definite gap between where the sleeve starts, the valve starts. You'll see a dot there, and the dot marks the point of transmission between the porcine sleeve and the valve starting point of the bovine valve. I'm going to take an aortogram now so you all can see what I'm saying. Couple on.
Yeah.
So that looks nice. I'm going to just go a little bit more LAO. A bit more, a bit more, a bit more, and stop there. Good. The reason why I did that is that, I don't know if you noticed, the base of the valve was not perpendicular. There was a bit of circularity on it. So what we did then, you can see that there's a bit of circularity in the base of the valve. So the next view then will show you, I think, so you can see it off. You can see there's a lot more perpendicular.
Change it a wee bit if you want. Modify it slightly.
We'll start releasing and then we can adjust it. We may need to go more caudal when you're releasing. So, okay, we can start releasing now. Now this valve will move forward as we're releasing. So Mark's going slowly. And you can see that the valve is already moving a little bit more forward. So keep going. a shot there. Store that, please.
So the other thing about the, worth mentioning about the portico valve is that generally the hemodynamics are very stable, and during the opening process, there's no drop in blood pressure that you might be familiar with the evolute.
That's a nice depth that you have
you've
now.
seen from the slides, what we're aiming to do is to try to keep the first intersection. Yes, and what we're aiming to do, Eberhard and Ajay, is to have the first intersection just above the annulus plane. And I'm just going to come back tiny bit. Okay, just go slowly.
So you can see the device hasn't really started to flower yet. So we're going very slowly just until it starts to open.
Stop.
So it's just about to start opening now.
Stop for a second.
So we're really trying to optimize the position at this point.
Stop, please.
Yeah, and you're
Blood
not,
pressure is perfect, 160
you're not
over
working
50.
with the wire, right? You
For
just
sinus rhythm, narrow QRS.
Okay.
you're
I'm
basically,
not working
Well,
the wire. My concern is, Eberhard, we have. I am concerned about perforation here because of the small cavity.
I think the wire is fairly, I can feel it pretty much against the ventricles. There's not a great deal of space there.
so you control the position
So I think it's reasonably
with
splintered
your
against the
both
heart, so I
hands,
think it
right,
should be fairly
Ganesh?
stable.
With both hands, yes.
Yes.
And the other concern I have, Eberhard, is I'm not feeling very much, because of the stiffness of the whole anatomy, I'm not feeling any transition of energy from the valve and the patient. So I am a little bit more cautious than normal.
Yeah. But the depth
Because
looks
normally
very
you can
nice.
feel a bit of, heartbeat tension. I'm not really feeling
So
anything
you
at
can
all.
see the valve it's starting to reach across now. You can see the pressure
Starts to flare.
has stayed rock solid. There's no change whatsoever.
Stop that and just store that for me. Let's take an aortogram now. I like that. So maybe
Yeah,
come a little bit
very
more
nice.
photo. A bit more. Okay, and store that. Stop that. Coupling off. You can see now the bases are fully aligned, Eberhard and SJ. So
Yes.
we're going to keep going slowly now.
So we're truly seeing the inflow portion of the valve
It flares against the left. That's great.
in alignment.
Coupling on.
So our pressure is rock solid, so there's no drop in pressure. I'm just continuing now, and we've reached across.
Very nice position. It is horizontal.
And I've opened the lock. I've just gone past that. That's a 60% spot. I've just opened it there with my hand. And we've gone right through. You saw barely a change in blood pressure. The only change we've seen in the hemodynamic trace is a very reassuring appearance of a dicrotic notch.
Okay, coupling on again.
We've got a diastolic pressure of 60, a systolic pressure of 153, sinus rhythm. We've just occasional paced beats.
So just center on the valve again for me. So Eberhard, what I'm trying to do now is something we've started doing in the Eberhard is to try to center the device into the middle of the aorta. And then hopefully then when there's not major changes in final release. We have really lovely hemodynamics and good rhythm as well. The patient is still comfortable. I'm going to now gently release a little bit more, Mark. So you saw Mark release in the lock. We can go up to the radio opaque part before final release. And we're going to do that, I think, slowly.
Very slowly here, okay.
Yeah. Now stop there. So I'm going to take an angiogram first, coupling on. I like that. So I'm going to take the pigtail out. So there are people who leave the pigtail in and some don't. I take it out. In this patient, I would take it out because of the angulation. I'm just concerned that we might get stuck there. So Mark's going to go very slowly release this valve.
Okay, I'm going to release.
Yeah.
I always feel uncomfortable without the pigtail.
I heard that, Eberhard.
I know. I tried to whisper to
So we're
Paul.
still releasing the valve, and so far looks very stable.
It looks very nice. But it is a horizontal aorta, Ganesh. Okay, now it's releasing.
It is, yeah.
See that part? I'd like to have pigtail.
So I just think that one of the leaflet just got released there. Okay, so Don't pull, yeah. So just need to confirm the other one.
Yeah.
So store that and coupling off. So this valve has 3 anchors. I can see 2 very comfortably. I'm not sure of the third one. So what I'm going to do is maybe take another view. Okay, store that. That's now come off. I just moved very forward. Store that, yeah?
Yeah.
Okay, let's take this device out.
So we will just take the wire clear here. It pulls the nose cone to the center of the valve, and we'll just let the valve
Lift the wire on a pre-shaped curve, it lifts the nose cone, a bit like lifting a skirt, although I don't know anything about lifting skirts. But that's what it does, and then you can safely take the nose cone out of position.
So what I'm doing here is now just sliding back the nose cone into the device to dock it.
The pressure looks
there's it
beautiful.
docked.
Diastolic
And,
60,
just
that's
make this
nice.
oversheet a little bit. I think so.
I think it's okay, Ganesh.
We're going to keep the wire in, take the device out, and then, so like all of these self-expanding technologies, I think it's always nice to wait for about 10 to 15 minutes. And we do have time here, so why don't we do that? Let's take a pigtail in. So we have a diastolic of 67, 68 and a systolic of 184. So what we normally do now is to start the patient on some IV nitrate.
So about 9 o'clock, so.
No change in rhythm?
Maybe some bundle branch.
So far, no, which
Yeah,
is
so
great.
and this is what we were hoping to achieve, retain
Wow.
our sinus rhythm. The QRS remains narrow. We did have the occasional paced beat during implantation, but it looks like we haven't worsened things in any way. So hopefully
But,
she'll largely run on her own rhythm.
Wet gauze, please. Thank you. Okay. Yes, please. Let's do that.
Pressure.
And the wire again, just to cross the valve.
Are you trying to get into the ventricle?
Yeah, just to show gradients and stuff. You know, we have about, I don't know, 30 minutes or so. And also what I'm trying to do is trying to clock up that 10 to 15 minutes rather than just looking at mark and the patient.
It's always worth just advising going through on the pigtail in case you pick up a cell with the wire. You can snatch defeat from the jaws of victory.
Okay. So let's see the hemodynamics now. I think, really it's lovely. We have a good dichrotic notch,
Very
really
nice.
good separation between the diastolic phase of the aorta and the end diastolic LV pressure. There's no gradient.
Are you seeing the hemodynamics?
So, based on this hemodynamic, started diastolic pressure of about 65, 66. We now have a diastolic pressure about 61, 64. It's still only about 5 minutes post-implant. This
Very,
valve
very
will
nice.
continue to expand with time.
I like-
Ganesh,
Go
are you
to,
going to rely on your
RAO?
your pacing? Why? Because your balloon, your pre-dilatation balloon ejected when you pre-dilated, and
Yeah. Well, we can rapid pace even more. Maybe we'll go a little higher.
It definitely didn't break.
The valve seems move a little bit higher, as expected. Is it?
Yes, it's interesting. So as we were deploying, I did push quite a lot forward when I saw that happening. And I think this is one of the
You know, it's one of these things,
one of the
Ganesh.
challenges
It's
of
really surprising.
these
You have
valves where it's still attached until final release.
an excellent diastolic pressure and more AI than expected, you know?
True. So, you know, I think, 5-10 years ago, Eberhard, we would have left that. But I think today we're in a position where I don't think we should leave that.
G-
You will do the post dilation, and there is some shortening of the, maybe the possibility of the migration.
Right.
So the patient age and the hemodynamic state, we have to think about that, and just let it alone is the option.
Yeah, because the hemodynamics are really good.
So we are really afraid of.
I know.
It is a little bit of an anxious.
Concern about the device migrations after the post dilations in up to the aortic side.
Pull back. Pull back.
Mark, what size balloon
Yeah,
are
it's
you going to
definitely a
use?
worry with the relatively high position.
What size balloon are you going to
25.
use to okay? Because you have oversized the annulus.
So we knew that we're using 25. The maximum diameter of the annulus is 24, so 25, I think, is the most we're going to use. Okay.
Yes, it will be, Pat.
I mean, interestingly, our acute LV EDP was 27 millimeters of mercury. It's now down to 17. So, again, that would mitigate a little bit hemodynamically against worrying about this at all, but it is hard to overlook the fluoroscopic or angiographic appearance.
How many minutes has it been since deployment? Can I just ask? Jenny?
Maybe 4.
So it's Jenny and Paul as well who are CPs who make sure we do all the
I
right
think we're
things
about
at
9
the right
minutes
time.
from implantation.
You know, actually, it's
So
quite...
10 minutes,
it's been
yeah.
10 minutes. I'm just wondering if you all agree whether we should do one more aortogram, because as you correctly say, I am also concerned about let's go to the implant view again, about post-dilating a valve that needs to be high when we have, quite frankly,
I was
really good hemodynamics. Huh?
I was actually thinking, Ganesh, maybe you can wait a little bit because the hemodynamics are really good. Patient is very stable,
Yeah.
and you might actually not,
And she wants to have a breakfast, so...
Our patient's quite hungry. She wants to get back for some breakfast, she says.
She's asking me what's taking you so long. So, you know what? So, the other thing about the portico valve is, and it's important, I think, to bring that in. I'm not trying to fudge the story. You know that the spacing between frames are much wider, so there's more tissue between frames. And although hemodynamically, under normal hemodynamic conditions, you can get no leak, under pressurized conditions, you could have a forced leak. because there is a discrepancy between with what we see hemodynamically and what we see angiographically. And so maybe what I might ask this time is, Colum, can we do a quick echo now? Because we have very good views of the valve. We have time, so let's do the echo. And let's see what that shows. And that gives us a bit more time for this valve to continue to expand. If you all agree.
Yeah.
Because I share the concerns all of you have raised. So we do have honestly, a really, really good result on an 88-year-old lady. And trying to be too clever and too smart may not be the right thing to do.
Anyone in the panel that would not post-dilate?
Eberhard and SJ, the panel, what do you all think?
Dr. Hong, post-dilate, yes or no?
No.
Good.
Definitely
Next.
no.
No?
I would wait, but if the aortic regurgitation didn't improve, you'd subjecting someone with a hypertrophied ventricle to aortic regurgitation, which you didn't have, and so she's not going to do well. So I think I'd wait. I agree with the strategy. Yeah.
SJ, would you post-dilate?
No.
Paul?
I will wait, but yeah, remember this patient doesn't have AR to begin with, and it's a small hypertrophy to the ventricle. So
Yeah, and you?
No, I will wait.
So, Ganesh, that's very interesting, actually. With those hemodynamics, patient being stable, 4 panel members essentially would say no post-dilatation, and 3 would say wait, because there's a lot at stake here, and you're not losing anything except a few minutes. And also, remember, this is also a self-expanding valve, which might get better over time. Not that I'm trying to downsize the AI, but I think given the hemodynamics and given the position, I think it's very reasonable to wait and see whether that improves.
I would like to raise an issue that when the angiography finding is not
very
compatible
grateful for
with
your
the
opinion. I think,
hemodynamic finding,
It always is
which one should we
reassuring that,
count out?
like all of you, we go through
That's
the same challenges on what to do.
It's TTE, right?
And I agree with all of you. I think wait and see is the right thing to do here.
Yeah.
Can you all see the echo?
Yeah, we can see the echo. Mhm.
It's not so easy with her on her back. To get good images, but it's
And
just quite a
the
tough
left
subject.
ventricular end-diastolic pressure remains stable.
It's actually improving. That's just either, I don't know. It was
Well, that's
We just
another
pulled-
point. I
we
mean,
just pulled the catheter back for the echo, so
I'm
it
always
was
a little
22 and then now down to 17 and
27. Sorry.
so 27 down to 17.
Yeah, Ganesh, when you do a PVL check with
So before
aortogram
we did,
in LAO, you have a foreshortened ventricle, and that might actually increase the contrast to a degree that you don't see when you do that in RAO. And I would be very careful. If there's any doubt, repeat that after a few minutes in RAO, so you can see maybe a little bit better what it is, because it's quite disturbing.
Eberhard,
Yep.
and the other thing as well is you've now seen 3 views on the echo, and honestly, I'd see no more than trivial leak on the echo.
Yep. I agree with you.
And I think, I'm not going to post-dilate here, actually.
That's
I think no matter what I see on
Probably
it,
very smart, very wise.
hemodynamic, which is stable throughout, the patient's getting hungry. I'm going to do an aortogram as you advised on the RAO view. And then I think I'm going to stop no matter what I see, unless there's severe leak, because, and I don't think there's severe leak because we don't see it on the echo.
Well, the the left ventricular
so let's do
end-diastolic
that.
pressure remains the same. Echo trivial, hemodynamics good. I tell you,
need a standard wire after crossing it.
400 PSI.
I think the waiting
Sorry,
pays
Eberhard, I
off.
missed that. What were you saying?
Picture again.
Can you hear me?
Yeah, everyone.
Picture. SJ wants to see a picture. Do you think you can do a picture?
And also, the pigtail, when you do the
We're going to do an
aortogram,
aortogram
maybe
now.
not too close.
Okay.
to the
Aortogram.
Yeah, we'll do that now for you. So center on the valve for me.
And be sure the pigtail is inside the valve,
Okay,
not
now go.
outside, because the cell
Ario,
size
no
is
good
so
Ario,
big.
please.
You can easily
True.
shoot. Yeah.
Yeah, you can shoot
Yeah.
around the valve.
Yeah, that's right.
Yeah.
It's true.
Please,
Paul
yeah.
is always very smart.
Go to RAO and then stay on the ventricle, please. And then, yeah, that'll do. Okay, just see a bit more the LV. Perfect, okay, that'll do. Okay, coupling on.
Hey.
That's much better, huh? So we increase the volume as well, just to be sure, and that's a much, much better result. So I think that's the best thing to do, not to do too much. So we have time, so I'm going to keep talking while we'll stop at 9:25 to close the session. So we have some time, and I'm going to just close the hands. Could somebody just come and... Sorry, sweetheart.
Very nice, Ganesh.
So the way we close the valve, I've got already the sutures put in. I'm going to now, we normally tend to put a wire across the sheet to protect it. So we have the time to do it, we'll show it to you. So we have an AL1 catheter to engage the ostium of the leg.
Well, Ganesh, a trivial question. Because of the difference in
Okay,
the
let's come down
strut,
to the leg for me.
the difference in the
Yes,
strut
yes.
design, do you
Yes.
think portico, in terms of radial force, is it weaker or stronger or the same to a core valve or Eberhard? I mean, in a situation like this, should we wait for longer or?
Yeah.
That's a very good question.
Paul always asks very good
That's
questions.
a really good question, actually. So on the bench testing, the engineers, I've been involved in the program since first in man, and also the core valve as Eberhard has been. On the bench testing, the core valve and the portico radial force appears to be similar. I think what is different about the portico is that it has a far less metal to tissue ratio. So when you have frames that are not there in a given set of time, then it's likely that you will not force against that area. So in every millimeter, you have more metal in a core valve or a lotus than you would with.
Yeah, that's better. Fantastic. Northern Ireland. We're back to the Olympics. Okay, so I guess we got cut off by the satellite. This was exciting, SJ. It was great, the panel members, and for the auditorium. Quite a learning here. What we've learned a lot during this portico deployment. Ganesh obviously is a very experienced operator. He deployed this valve very beautifully. Don't do too many things. If you think it was more a spontaneous, oops,
Okay, table
that's
down.
what we didn't expect.
Table down, not push up, please.
Be
Table
careful.
down to you. Not
We were
push up,
just
please.
talking about the Olympics, so
Pull the sheet.
you're a champion.
Are you all back?
Yeah, be careful what you say because we're on
Did you
air.
go and have a quick cup of tea?
Yep, we will. But Ganesh, I
know, I heard everything.
Good.
And thank you for being so complimentary.
No, it was excellent. It was an excellent demonstration, and we learned a lot here. And I have to say, this was very, very, very nice. Well done, and thanks for having us. And hopefully, the patient can walk away tomorrow in the minimalistic approach. No, but thank again, Ganesh and the team, for doing this transmission. We are very excited with an excellent result. Hopefully, we see each other soon. Latest London Valve, right?
Absolutely. So on behalf of everybody here, we are very, very honest and grateful to be part of AP Valves 2016. Thank you for the invitation. We hope we met your expectations. We hope we were able to transfer some information on how we do things under local anesthesia. Normally, the average discharge time for our patients is about 2 to 3 days, Mark, isn't that right? Yeah. We will be mobilizing this very early in the morning, so hopefully she'll be mobilizing later on today. And if she's actually very well, she's independent at home, so she might even go home tomorrow, which is less than 2 days, Tavi. CJ and hemodynamic status. I've just taken out the sheet, and normally we'll wait for about 5-10 minutes to look at it. Maybe we'll take a quick angio now, and then we'll say goodbye. But once again, thank you very much for having us.
You exceeded our expectations,
Ganesh.
Ganesh.